Again, welcome everyone to our webinar series on evidence-based practices in crisis care. Today we'll be talking about follow-up care and suicide prevention. Before we get started, I want to take a moment to ensure that everyone in our audience is ready and comfortable with the technical aspects of this webinar. As you'll see, closed captioning is enabled for today's webinar. We also have American Sign Language capabilities enabled in this meeting. You can activate this by clicking the interpretation icon on your Zoom navigation bar. If you need tech support during today's webinar, please send a chat to the hosts and we'll be able to address that for you. Lastly, if you have questions during the presentation, you're welcome to enter them into the Q&A area. These questions will be sent directly to the presenters and moderators, and we'll make sure to queue those up in our Q&A session. Next slide, please. Our disclaimer: the views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, or SAMHSA, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Today's webinar is hosted by SAMHSA's 988 Crisis Systems Response TTAC. The Substance Abuse and Mental Health Services Administration, SAMHSA, has selected Altarum to provide training and technical assistance support to territories, states, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Crisis Continuum of Care. Along with our partners, W2 Consulting Corporation and Change Matrix LLC, who both have extensive experience with crisis services and technical assistance, the CSR-TTAC was formed to support the continued growth of the 988 Lifeline and build a more robust crisis care system. Next slide, please. We'd like to recognize and thank our SAMHSA partners who make all of this work possible for us. We'd like to recognize Jill Mays, who's the Division Director of Crisis Systems Transformation for the 988 and Behavioral Health Crisis Coordinating Office. Next slide. Today's webinar is brought to you by our workstream team. So in addition to myself, Megan McGregor, I am joined by Bree Carr and Jennifer Sedavi, both of whom contributed significantly to this presentation. We're so thankful for their support. Next slide. Our objectives for today's session will be defining the role of follow-up care in the suicide prevention continuum. We'll identify the core components of safety planning for clients at risk of suicide, learn to understand the concept and application of postvention as prevention, and we'll assess challenges to effective follow-up care and identify strategies to overcome them. Next slide. I think it's important for us to frame the idea of follow-up care within our national guidelines. So within each of the pillars of crisis care, follow-up should be an established component. Sometimes we think of follow-up care as potentially being its own fourth pillar, but that doesn't mean it shouldn't be involved in every step of our crisis care continuum. So in that first pillar of someone to contact, we know that in the National Suicide Hotline Designation Act of 2020, it required all staff to be trained to provide follow-up services. In terms of our someone to respond, mobile crisis teams models should identify available community resources and supports for individualized follow-up care. And then in our final pillar, a safe place for help, the coordination of follow-up care during transition from crisis stabilization. That's an intricate part of our postvention and prevention planning. So it's important that we identify follow-up resources within each pillar of care, depending on where we're interacting with our clients. Next slide. So let's level set a little bit and talk about what the impact of suicide has been. It's likely that all of us on this call have been impacted by suicide in some way. Suicide can have small and large impacts. It can be impactful on individuals and families, as well as communities and systems. Between 2000 and 2022, suicide rates increased by approximately 36%. In 2022, it was the second leading cause of death for individuals aged 10 to 34. Now I want to talk about this in terms of the iceberg. Many of you may be familiar with this analogy, where the issue that you see above the surface isn't nearly as large as the entirety of the issue. So in 2023, 49,266 individuals aged 12 and older died by suicide. But for every one suicide death, we see at least 10 emergency department visits for self-harm, 48 self-reported suicide attempts within the past 12 months, and 325 people who seriously considered suicide within the past 12 years. So when we add all of that together, the number of those impacted by suicide grows exponentially. Next slide. Follow-up care for suicide prevention is crucial. Many individuals face challenges after discharge from crisis stabilization. It's actually one of the highest risk times for these individuals. We know that up to 70% of individuals who attempt suicide did not attend their first appointment or maintain treatment after their discharge from care. Additionally, a June 2024 study revealed that 1,148 hospitals surveyed, only 4% met the full criteria for implementing recommended suicide prevention activities at the time of discharge based on the Joint Commission's National Patient Safety Goals for Suicide Prevention. So we know that there's lots of work that we can do. Next slide. So to help us in doing that work, we have our crisis follow-up collaborative and self-directed care presentation for you. Next slide. We're joined today by Amy Malloy, a Senior Project Associate at EDC. She is a behavioral health expert with 15 years of leadership experience in suicide prevention, mental health promotion, veteran services, and education. Currently, she's a Senior Project Associate at the Education Development Center, EDC, where she advances the use of innovative training practices and continuous quality improvements to sustain system-wide safer suicide care. Amy primarily works on two projects, Zero Suicide and the Multi-Tiered Suicide Prevention for Schools. We're so grateful to have Amy with us today. Welcome.
Thanks, Megan. Thank you so much. And it's so wonderful to see so many people joining today's webinar. As I was preparing for this presentation, I was reflecting first on the important life-saving work that you all do along the crisis continuum and in treating individuals with suicide ideation and behaviors. So the question that I hope, or at least I hope I can answer, or at least begin to answer with the time that we have, is how do we strengthen the work that you're already doing by providing follow-up care that is both collaborative and self-directed, but also encourages individuals to engage in treatment. So the next slide, when we think about some of the statistics that was just shared, and I'll offer up some of my own as well, it can be kind of disconcerting, right? We work really hard to identify individuals with suicide risk and support them through a crisis. They work really hard in that moment, as do their families and supporters, but sometimes getting them connected to treatment is a challenge. And this is so for so many reasons. Sometimes those reasons are specific to the individual, and we'll talk a little bit about that, but sometimes they're systemic. And so it's really important that we address both of those. On a personal note, I'll share that I started my career as a clinician in intensive outpatient treatment for individuals with substance misuse. And I learned pretty quickly, or realized pretty quickly, that, and partly due to the death of a client by suicide, that the individuals could be working really, really hard in their recovery, and yet there were these challenges that got in the way. And so sort of turning my attention to thinking about how do we mitigate some of those challenges, that's where I chose to do my work. Whether those challenges were relapse or difficulty engaging in treatment, they were still challenges that I think at a systems level, that's perhaps where some of those solutions lie. And so I bring that perspective to you today. Also, I want to share that the follow-up care strategies that we talk about today, some of them you may already be familiar with, some of them may be new to you. So I'll do the best I can to answer any questions and perhaps provide some additional information that will be helpful for you in developing kind of best practices for your implementation. I chose this image intentionally because I think of all these strategies, each strategy, each intervention on its own can be helpful, but when we bundle them together in a way that is most appropriate for the individual, that can be implemented with fidelity, and that is sustainable for organizations, we can really promote that safety and continuity of care. So I really sort of pose to you today that if you're using a couple follow-up strategies, that's wonderful. You're partway there. Part of it is bringing in a lot of different strategies to meet the needs and experiences of the different people in our communities. So on the next slide, we'll get started. I do want to note that I will use terms follow-up care and care transitions interchangeably during most of the session. Care transitions is the term that we use in Zero Suicide. In a Zero Suicide approach, care transitions refer to the strategies that we use to support individuals as they move from one level of care to the next. As you heard, that's a time of increased risk. Research indicates there is a 300% increased risk for suicide in the week after discharge from psychiatric inpatient stay, and a 200% increase in 30 days after discharge. So the strategies that we use during these times and the care that we provide during these times really matters. For the purposes of this session, I'm also going to include evidence-based brief interventions like safety planning and lethal means safety in our discussion, as well as the care we provide in follow-up. To learn more about zero suicide and some of the strategies that I'll be sharing today, we have set up a web page that will easily connect you to some of the links for the resources we're talking about. So there'll be a QR code at the end, but I did just drop that in the chat as well. Next slide. So I want to just get us started with a brief review of the suicide prevention care continuum to kind of ground us in what we're talking about and to identify where and how we can best provide some of that follow-up care. And then we'll move into a case example. When we talk about prevention, some of the community-based strategies that you're all familiar with are the widespread promotion of 988, education and awareness to communities with trainings like Safe Talk and QPR. But we don't always know when an individual is having thoughts of suicide. So another important prevention strategy is universal and targeted screening of individuals across all settings. So health and behavioral healthcare settings, higher education, K-12. I saw some folks joining us from corrections. That's an important place as well. And then also we want to attend to building those protective factors that help mitigate risk. That's all part of prevention. And across the country, a lot of this work happens in community coalitions because everyone has a role in preventing suicide. But in prevention, the main place where we see an opportunity for follow-up care is in that suicide risk screening. Very often, a person is screened for suicide, and if they screen positive, they're handed a referral and encouraged to make an appointment with someone in the community. This exact thing happened to someone close to me recently, and guess what? They never made that appointment. And there's a lot of reasons for that. Maybe it doesn't feel urgent, and so they think they can handle it on their own. Maybe they feel like, well, I told you I was having thoughts of suicide and you didn't really care, so what's the point? Or maybe they get home with really good intentions of making that phone call, but there's so much going on and they get distracted and it just gets pushed further and further away. Any of these reasons would be understandable, and you probably can relate to many of them in the work that you've done. Again, the solutions is at the systems level. So a question that I pose to all of you, you can answer in the chat, is what are some ways that you increase the likelihood that a person who screens positive for suicide gets connected to a professional in their community? What are some of those follow-up strategies that perhaps you all employ in your workforce? Follow-up calls. Great. Thank you, Jennifer. Caring cards. Love it. Ooh, this is moving quickly. I'm going to miss some of you. I see quite a few caring cards. I think that's like caring contacts. We'll talk about those. Home visits is great. Follow-up calls. Anthony says they have a particular cadence to their calls. So 24 hours, 1 week, 1 month. And I imagine that this is coming from most of you in crisis work. Unfortunately, in other places in the community, we don't get the same kind of response. Very often it is kind of like, here is a referral. So the work that you do is incredibly important. And I appreciate you doing that. I also see references to peer outreach and warm handoffs. Really great. Thank you. Then we move into intervention. So something to consider here is that a suicide risk screening only tells us there's risk. It doesn't tell us about the level of risk, right? So this is a clinical conversation that helps us better understand the level of risk and formulate a response that's appropriate to that level of risk. And then thinking about how do we connect that person to help. Something else that should happen here in interventions, a brief intervention like collaborative safety plan and lethal means safety, which we'll talk about in a little bit, but also direct treatment of suicidality. And you may not be familiar with this, but there are some evidence-based suicide-specific treatments that are available. And this is important because for a long time, we thought that if we treat the underlying contributing factors to suicide, a mental health condition, interpersonal conflict, a personal loss, if we could treat those things, those thoughts of suicide go away. And what we've really learned is that we need to treat the suicide directly in the least restrictive setting. That's important. Treat it directly and do so in the least restrictive setting. So, evidence-based treatments for suicidality include cognitive behavioral therapy for suicide prevention, dialectical behavior therapy, and collaborative assessment for managing suicide, known as CAMS. You may be familiar with that. And then while people are trying to get to these appointments, because we know in practice it often takes time for that to happen, we want to provide some follow-up care. And so those are the strategies we'll be talking about today. And then turning our attention to postvention, the last thing I guess I want to say is that it's important to acknowledge that despite our collective efforts, our best efforts, individuals in our care and in our communities will die by suicide. Postvention is those policies and practices that guide our response. There include two key activities: grief support for those who are impacted to help promote healing, but also monitoring for increased risk. And this is an important area where we'll talk about follow-up and how important that is and what it could look like. Because the people in the community who have been infected have been directly impacted, whether it's family members or friends, and even those who might not necessarily know the individual, but already had some vulnerability to risk due to their own suicide ideation or history of attempts. There's increased risk for all of those individuals. So we want to make sure that we're providing some extra support, some extra follow-up care during those times of postvention. And at the same time, there's often some activation of other community level suicide prevention efforts, like increased promotion of 988, increased screening in communities, or information about warning signs. And this is really what we mean when we say postvention is prevention. Next slide. So I want to walk you through a case study. And this will be an example just to kind of get us thinking about what a process might look like and identify, and for you to share some of those areas where you already are providing some follow-up care. You all did such a great job in the chat already. So first, let's imagine, number one, that we're in a community in the rural Midwest. Jim is a 48-year-old male. He's being treated for a diagnosed degenerative medical condition for which there really is no treatment. And he has been thinking about suicide. His wife, Rita, works at the library, and she recently took part in a Safe Talk training. She begins to recognize some of the warning signs that Jim is sharing, and she asks him directly if he's having thoughts of suicide. Jim responds that he has, and he thought about ending his life using his hunting rifle. Rita remembers seeing a 988 sign at the library, and so they call crisis together. Number two, the 988 call center staff conduct a risk assessment. As mentioned earlier, this helps them to better understand the level of risk and how to make an appropriate response. Number three, they engage Jim in collaborative safety planning. This is that first brief intervention that's really going to help support and ensure some level of safety. They also include Rita in that because it's important for us to include care providers or caregivers in those conversations. The call center staff provide lethal means safety, and they help Rita and Jim decide on a plan to temporarily remove the firearms from their home. They also recommend that Jim goes to the local crisis stabilization center. So at this point, I ask you, what are some of those follow-up care things that might happen to increase the likelihood that we get Jim to stabilization? Some of them are going to be what you all talked about before, right? Those follow-up calls, maybe a warm handoff. Is there anything different that you might use in your setting? Pathway to Care program. Thank you, Elizabeth. How about related to lethal means safety? Does anybody provide follow-up to lethal means safety? Giving out gun locks, absolutely. Asking Jim, what do you think of the intervention so far? Absolutely. Doing a home assessment, maybe. And then In addition, I would recommend following up with Rita, maybe the next day, to say, how did that plan work for you? Were you all able to implement the plan that you had in mind? So it might be, thank you, Carrie, it might be the mobile crisis team calling back to check in. So these are all important follow-up activities. So now we find Jim in number 5 at the local crisis stabilization center. He's had an opportunity to meet with a social worker. He's participated in some DBT skills. He's met with a peer support, and now he's moving out into the community 24 hours later and is discharged back home. The work that's done in crisis stabilization actually really sets the foundation for what those follow-up care will look like. So as I said, he received some DBT skills groups. This makes it really, I'm going to say easy, so that if there's some support groups available to him in the community, he's already started to build those skills and maybe is more likely to attend those groups. He's met with a peer support person, so he may be more likely to continue to meet with peer support outside of crisis stabilization. And again, there's probably some services that Rita received as well, maybe some psychoeducation for how she can support Jim or how she can recognize another emerging mental health crisis. These are all things that will support and build upon those continuing care. Unfortunately, what we know sometimes happens is that it may be weeks before Jim can see that care provider. So having these things in place, connection to peer support, the beginnings of learning DBT skills, having a good safety plan, having follow-up on lethalamine safety, getting support for Rita, all of these things help maintain safety. They support Jim's engagement in treatment, and they increase the likelihood that Jim will be able to get the support, ongoing support that he needs. And then finally, the next click, Jim's suicide plan has been going really well. He is engaged in weekly therapy sessions with a CBT suicide prevention trained clinician. And 7 months later, he's able to leave his suicide care plan, treatment plan. Jim and Rita are feeling really confident in their ability to help him through recovery and also manage a crisis later should it occur. So we'll dig into some of these transition strategies, brief interventions, and care follow-up care. And I can see that many of you already have a very good understanding of what these look like. But I think this is just kind of an illustration for us of the opportunities that exist, given one just case example. There are so many different examples, as you know, in the community. So on the next slide, I want to talk a little bit about some of those follow-up care opportunities in more detail. So as we've already shared some statistics about the lack of engagement in treatment following a suicide attempt and the increased risk following inpatient care. But also what we have learned is that building effective follow-up care into the crisis response continuum is key to saving lives through brief interventions like collaborative safety planning, caring contacts, care coordination, and peer support. These have all been shown to reduce subsequent suicide attempts for individuals who presented with suicidal thoughts or behaviors in the ED or some other medical environment. And I should have said earlier that that website that I dropped into the chat earlier that you'll see again at the end, we have the citations for these statistics there. So first, let's turn our attention to caring contacts. If you're not familiar with caring contacts, we usually refer to them as non-demand caring contacts because these are not calls to say, have you made your appointment? Have you filled your prescription? Have you activated your lethalamine safety plan? These are literally just contacts to say, you got this. We care about you. We're here for you. These are supportive messages, affirming messages. They include things like a reminder about 988 or any crisis care services that are available in the community, but they don't ask for anything. They are simply just a way to check in and say someone's thinking about you. And there's some good research that indicates that this can be very effective in not only keeping people engaged in treatment, but also helping to maintain safety. Typically, there's a regular schedule. So if it's an inpatient provider, for example, that's providing caring contacts, they might send that first one out 48 hours after discharge, and then 1 week later, and then 2 weeks later, and then 1 month later. And this might go on for 9 months at a different cadence. Organizations have the ability to develop these caring contacts in a way that is most feasible for them, but also the means of these contacts can also vary. So some send a letter, some send a postcard, some have invested in some text messaging apps that give them the opportunity to send these messages via text. It's a relatively low lift for organizations, although that varies depending on the capacity and the number of people that you might be sending contacts to. But it does require some kind of administrative coordination of who gets the cards and when. Another thing that some organizations have done is they've engaged the people that they serve in creating images for the postcards, or they engage the providers in writing handwritten messages to the individual. So there's lots of different ways you can do this. And on the Zero Suicide Toolkit, they have some really great images and cards that you could actually just download and print yourself. The next is care coordination. Oftentimes, again, this is like a follow-up phone call, much like you all had mentioned. It could also be, though, meeting people in the community. And I saw a few people send home visits. Under care coordination, obviously, you're going to coordinate care, but you can also provide some psychoeducation and some problem solving of those challenges that might arise and get in the way of people being able to access treatment. This could include support for the individual, but this might include support for their family, their supporters, their caregivers as well. And then finally, peer support. And this is probably one of the most beneficial ways, and also an area in which you can do a lot of different things, again, depending on what's most feasible for your organization and maybe what's available, to you. Similar to care coordination, the goals and the objectives are the same, but it's delivered by a certified individual with lived experience. These individuals are trained, they bring their own lived experience. It provides this kind of extra level of support. They're often also trained to review safety plans. They might be trained to do ongoing screenings. So in case there's some concern about how the individual's risk level has changed, they can do some screenings. They also could teach DBT skills, different than DBT therapy, but they can teach DBT skills. And so these are just some of the examples. There really are a lot of opportunities that exist. Many of you mentioned warm handoffs to the next level of care. The implementation of rapid access or open access models can be really beneficial too, as is like some other strategies to facilitate appointment scheduling. These all fall in the realm of operations, but I think that as crisis service staff and as clinical care providers, I would really encourage you to, when you see it as an opportunity, to advocate for these strategies. The other thing is two really important things to consider as you develop follow-up care strategies in your organization. The first is, do they align with the needs of your community? And then, as I've been saying, are they feasible? So with respect to the needs of your community, it's really important when you can to invite individuals with lived experience to participate in systems improvement efforts in ways that are meaningful. So something that we very often do are surveys. This is a very easy way to collect some information, feedback from the people you serve. What worked? What didn't? What can we do to improve? But there's also key informant interviews, focus groups, invitations to participate in a consumer advisory board. These are more challenging to implement, right? A little bit more time intensive, but absolutely worth the effort. I have a colleague who shares a story that they had a letter, like many of us do, that you send to someone who has missed, several appointments, and now they're considered discharged. And if they want to come back, they have to go through the intake process again. Most of those letters are probably very business-like. And in this organization, and it was somebody who had some lived experience, one day just said, you know what? If I got this letter in the mail, I would not come back. And so it got them thinking. And so from the input that they received from someone with lived experience, they changed that letter. It wasn't a heavy lift, but it made a really big difference. So it went from being this letter that almost sounded punitive to being one that was much more caring and empathetic, that just said, hey, we haven't seen you in a while and we're concerned. If there's something that's kind of, getting in the way of your appointments, let us know. We want to help problem solve. If you relapsed, it's okay. We're here for you. Come back. And so having the input and the opportunity for people with lived experience to kind of help us look at and address our policies, our practices, our protocols, really think about, are they actually going to work for somebody, or are we just inadvertently creating more barriers? So I think that's an important thing to consider. How do you utilize individuals with lived experience in the design, delivery, and improvement of your services? And then, of course, you have to think about what's feasible. What is your staffing structure? What is your capacity to train and supervise peer support? Maybe you don't have the capacity to do that within your organization, but you can partner with another organization. So some of this work that happens in follow-up care isn't just within our own organizations, but it's within our partner organizations. Now, if you do that, there are a few things to think about. You want to make sure that you develop some clear protocols so that everyone is understanding what is their responsibility. You also maybe want to back that up with an MOU. You might want to include things like data sharing so that you can consistently monitor the follow-up care and see if it's working. And then also you want to provide an opportunity for communication so the two organizations can come together and say, how is this working? Is it still working for us? Are there some problems? Do we need more training? What does the data tell us? So there's lots of opportunities for follow-up care. Understandable that you might not be able to do them all yourselves, but think about those partnerships can support it. Next slide. So now that we've established some of those strategies, I want to dive into some of the challenges. And as we said, there's some, real clearly understandable challenges that can sometimes get in the way. We'll look at individual challenges first, and then we'll look at systems level challenges. So the first thing is that sometimes the crisis has been de-escalated. The person might feel someone has helped me. It's not going to happen again. Or I can do this myself. I have the support that I need. I know what to do next time. Sometimes this sort of lack of engagement or this sense of like, I don't need this really presents with individuals who maybe are repeatedly seen and then deny services. And this is a very common occurrence. I think one of the questions we need to ask is why? Like, we see you regularly. You don't want to engage in services. Can you tell us why? Is it because you feel better when you leave us? Is it because you've had a poor experience in the past? Is there stigma? So there's a lot of different reasons, but we can't address those until we know what they are. So the first step is really having those conversations with like, what is going on here? The other is, and I would just sort of posit this as something to try, but care transitions and follow-up care can provide an alternate means of support to treatment. So maybe someone doesn't want to engage in clinical treatment, but are they willing to meet with peer support? Are they willing to attend a support group? What are they comfortable doing? And when you have a lot of follow-up care, care transition opportunities available to you, either in your organization or in your community, you have options. And giving people options helps them become empowered. Maybe with a little bit of time meeting with peer support, they'll build some trust in the system or some hope for recovery or some confidence that they can do this. And that might change their interest in continuing with other treatment. So this is the first thing is sometimes that crisis has been de-escalated and it just changes the way we feel. Lack of social support's another one, right? They, again, see that they're doing better. The individual, their support people see that they're doing better. So they avoid the topic. They don't encourage them to seek help. Maybe they weren't really supportive initially. And so we see this manifest in people not coming into treatment. Transportation can be an issue. Finances can be an issue. There could be time commitments or caregiver commitments that get in the way, right? We see gaps in healthcare coverage. So many of these things, some of them outside of the realm of what we can address. But if we can fill those gaps with some of these follow-up care strategies, we might be able to at least keep people engaged until we can work through some of those. Certainly, some of these issues like having childcare arrangements or maybe, being pulled in different directions, caring for an aging parent, or concerns about what kind of impact it'll have on their job. We see this sometimes with teachers and law enforcement. There's lots of potential challenges that get in the way. Hopefully having some follow-up care strategies and care transition strategies will help keep them engaged while we think about how to mitigate those. And then sometimes it's that providers can't relate to my experiences or concerns. Maybe I don't feel like they understand me. Maybe because we've had different backgrounds or different life experiences. And then finally, a lack of motivation. Typically, people experiencing a crisis, the same things that sort of got them to that crisis continue to be a challenge even after the crisis. And that might be a reason for them to not engage in follow-up care in whatever means. Next slide. So that brings us to those systems challenges. Some of these you're going to see are the same, right? It's a lack of, training for our providers. We make this assumption that clinicians come into the workforce having been trained in suicide care. And what we've learned is that that's not the case. We have workforce study that we use at Zero Suicide. So many people just did not receive the training. And then again, we see that there's really limited trainings that provide direct suicide care, DBT, CBT, SP, and CAMS. Not a lot of clinicians come into the workforce with those trainings. So there's some training that needs to be done, and that puts a lot on systems. Workforce shortages is a concern as well. You'll notice that as I was talking through some of those care transitions, I didn't particularly say that any of them were done by clinical staff. We need to find ways to utilize or underutilize non-clinical staff. So care navigators, community health workers, peer support, they can do things like safety planning, lethal means safety, screening, but we have to build in a protocol that builds that workflow. Lack of resources, lack of funding. Some of this follow-up care, in fact, much of this follow-up care in most places is not a reimbursable expense. For some of you, depending on the state that you're in, or if you have some kind of grant to cover peer support, wonderful, but not everybody has that. And so we recognize that that is a really clear systems challenge. And then the lack of coordination and communication between partner organizations. As I mentioned earlier, sometimes you can't do this all yourself. You need to engage with another organization, but that requires coordination, collaboration, and a lot of communication. And then finally, competing priorities. We, as healthcare systems, as crisis care providers, are being asked to do more with less, and that presents some challenges on its own. So no answers here, but need to acknowledge that. Next slide. So what are some strategies for effectively building these care protocols, care transitions? I think policies and protocols is the first, right? Policies guide our work, but the protocols really outline who does what, when, and how. And when we have those clear, it just makes this so much easier. Staff need to be trained and they need to be supported. So they need to be trained in the interventions or the transition strategies, but they also need to get supervision and get support. There needs to be a feedback loop. So if a protocol is not working the way we intended, do I, as a care navigator, have the opportunity to share that, to express my concerns, to, highlight something that didn't work with leadership? Those feedback loops need to be included. Community partners, as well, would need to be included in that. The engaging individuals with lived experience, so very important. We want to include individuals with lived experience in the design of these follow-up services, in the ongoing implementation and evaluation of these services so we can identify areas for improvement. And then we need to consider, when needed, reaching out to partner organizations if we can't do it all ourselves. Engaging individuals with suicide risk is, another way to get some feedback. So certainly peer support is kind of a way of delivering things at that professional level, but you have consumers that you've been working with. You have individuals who maybe aren't coming back for treatment. Do we reach out? Do we have a conversation with them to get a sense of no pressure, no judgment. We just want to know why, and learn from those experiences. This supports a trauma-informed approach, and this helps us just do better. Again, like one example that was shared with me by one of our colleagues was that they were doing safety planning and they had really great data on how much they were doing safety plans. But when they did an audit of their safety plans, they all looked alike. And so, yeah, they were doing safety plans, but the question became like, were we doing them collaboratively? And so reaching out to individuals that they were serving, they realized that that wasn't exactly how the conversation went. So take a look at your data. If you are implementing any of these follow-up care strategies, take a look at your data. What is your data telling you? Consider also ways to support caregivers. Of course, this needs to be by invitation of the individuals that we serve. They identify the caregivers. Sometimes family is not the best support. Sometimes it's friends or chosen family. So help them think about not only who's most helpful to them, but how can they verbalize what they need so that those individuals can help them in meaningful ways. Maybe role play with them. How do you have a conversation with somebody who is one of your supporters, but maybe is always trying to just make it better and fix it for you and isn't listening as much as you would like them to? Helping them to really support the caregivers in their roles. To provide as much support as possible, and then providing support to them. Training is important. We don't just train people in interventions, but we also want to train them in the policies and protocols, and we want to give them ongoing support. So really avoid that one and done training, but how do we check in? I train someone in lethal means safety and safety planning. How and when do I check in with them to find out, have you used this intervention? How did it go? What were some of the challenges? And if there were challenges, can we talk about this together with other clinicians or other peer support and try and get a sense of what have they done before that has helped in the past? Certainly challenges arise in these interventions all the time, but sometimes more specifically in the populations you serve. So for example, if you serve a high homeless population and you're running into challenges, a great way to sort of think about that is to crowdsource from your colleagues. Like, what are some of the things that you've used in the past that have been helpful? What are some things that we can kind of, all share and pull from, strategies that will help us do better? So learning from each other is really important. Sometimes that's where the best learning happens versus like in that, didactic classroom kind of setting. And then finally, data. Collect and monitor your data. You need documentation on your follow-up care so that you can monitor for improvements as needed. So that's really important. You want to collect data on patient outcomes. You want to collect data on the process outcomes as well. You want to monitor for effectiveness. Using your electronic health records is a really, really great way to do this. And I'll talk about that more in a moment. Next slide. So actually, I'll talk about that now. So two examples of, again, commonly used, so I want to shift gears to safety planning. Two examples of commonly used plans are the Stanley Brown and the Crisis Response Plan, both very similar in what they include. Crisis response plans are often used with military and law enforcement populations. But essentially, they all start with the idea of recognizing warning signs, helping individuals identify coping strategies. The Stanley Brown separates out like what are your internal coping strategies versus what are your social distractions. So an internal coping strategy for me might be meditation or reading, but a social distraction for me might be going to the park and playing basketball, pick up basketball. Reasons for living is something that's unique to the crisis response plan, but is also very important and very helpful. Then there's the social supports and the professional supports. So in the Stanley Brown, for example, again, they're differentiating. You have social distractions. Those people don't necessarily know that you're having thoughts of suicide. Your social supports do. And so who are your social supports? Who are your professional supports? Who do you reach out to? When? How can they best help you? And then finally, the lethal means safety. In the webpage that I shared earlier, there's a link to the Zero Suicide Toolkit. And in the Zero Suicide Toolkit, there is a self-paced training called Counseling on Access to Lethal Means. It's freely available. There are some CEUs included with it. I can't remember off the top of my head which ones, but this is a great training if you're looking for more ideas and strategies for lethal means safety. Essentially, lethal means safety is putting time and space between a person and their means for suicide until the crisis passes. One of the things we've learned is that that period of time is very, very short. There's a graphic in Counseling on Access to Lethal Means that shows about half the people who made a suicide attempt had been thinking about it in the 10 minutes prior. So this idea of putting time and space between lethal means is really, really critical. Part of safety planning is keeping the environment safe and having a lethal means. Couple things to consider with that, like method substitution isn't automatic. So people have sometimes been concerned that, well, if we take away one means, they're just going to substitute it with something else. We've learned that that's not necessarily the case. So building lethal means safety into a safety plan is a really key intervention strategy. The idea of substitution is much less common than you think. All lethal means safety plans should include firearms and medications. Medications, because they're the most commonly used means. Firearms, because they are the most lethal used means. So including both of those in the conversation is really important, even if they haven't disclosed that that was their means. Also included in lethal means safety is the importance of being collaborative. So again, engaging families and significant others to support the removal of means. We don't want to put that responsibility on the individual with suicide risk. We want someone else to provide support, but we want them together to determine what is the best plan for us to keep the individual safe from lethal means, what feels comfortable for both of them. That is really important. And then follow up, as we said earlier, to confirm that that plan has been able to be implemented and that there wasn't any problem with that. So having this training, Counseling on Access to Lethal Means, I can't recommend it enough. It's free, it's self-paced. It might even be the kind of thing that you could do together as a group and have some conversations around how does this look in our organization? How does it look with the people we serve? What are the challenges we're coming up against, and how do we help each other problem solve, but then also how do we build this into our protocols and workflow? Next slide. Here I have an image of the Stanley Brown. Again, not the only option, but I do want to provide you with that. The strategies for effective collaborative safety plan are including education. So you want to educate the individual on why we're doing this, but also how they use it. So you want to explain this as you're creating the plan, really emphasizing their role and keeping it as collaborative as you possibly can. Also talking about how are we going to review this in the future and when are we going to review this in the future. Again, it's a collaborative conversation. So while most of the templates appear as a checklist, resist the urge to use them as a checklist. You really want it to be conversational. It is okay to prompt and encourage. There are times where we might need to prompt and encourage. Like maybe someone provides a coping strategy and we can see in our minds that there might be a time where it's just not feasible or not safe. Maybe I say that my only good coping strategy is going for a 5-mile run. And you're thinking, well, you can't do this in the middle of the night. That's not safe. You can't do it if it's raining. That's not safe. What if you don't have time for a 5-mile run, right? So you would prompt me to say, well, are there times where that doesn't work? And what might be another option, right? So we're still being collaborative, but we're helping to prompt through some of those problem-solving things. Again, engage supports whenever possible. Develop a plan to review and revise them, and then include that lethal means safety. One thing I want to say too about the review and revise, documenting your safety plan in the electronic health record could be really helpful. Most health records have either a template that can be included or the option to upload a printed version of a safety plan, for example. They also often have the opportunity to build in some kind of signal or prompt for regularly reviewing them at future appointments. So think about how you can use your electronic health record to facilitate that. The caution that I would say is this: if it does show up in your um, if it does show up in your electronic health record as kind of a form that gets filled in, you want to make sure that it doesn't, in your conversation, it stays collaborative and it doesn't look like you're just filling in a form for them. Make sure you use the individual's words. Don't use your words. If you need clarification, prompt them, but use the individual's words. Make sure that they leave with a copy. So it may be that you're putting it into the chart while they're sitting down and writing it out at the same time. That would work. Or maybe they want to write it out on an index card because they want something smaller for their wallet. So think about what are some of the ways that you can keep this collaborative, keep the documentation where it's easily accessible and in the person's chart, but they also have their own copy. There are some great digital apps that can help with that as well. And I think that's about what I wanted to say on safety planning, lethal means safety. Happy to answer any more questions that come in. I see a couple came in the chat. Thank you for answering those too, Megan. Next slide. So this brings us to postvention. Follow-up care isn't just important in prevention, right? It matters in postvention as well. And one of the reasons is because for each death by suicide, this is similar to that, the idea of the iceberg is that for each death by suicide, there's an estimated 135 people who were directly exposed to that loss. These are family, friends, neighbors, colleagues. So the same strategies that support safety, throughout the crisis continuum can also support safety following a suicide death as part of a postvention response. As crisis workers, as clinical care providers, as suicide care providers, be engaged in that postvention process as much as you can. Really support kind of that those opportunities to promote healing and reduce risk. We talk about postvention as being a socio-ecological response. So here in the darker circles, you see those relationships, the family and friends who are closest to the individual, and then there are other relationships. These may be people that you already work with, providing that extra level of screening, checking in, dose follow-up calls, finding ways to do some outreach during this time can be really valuable. But then there's the larger community that is also impacted, and how do we provide support to them? Because we don't always know who those people are who are going to be most vulnerable. In your practice, you may find that people who had their own history of attempts, even if they didn't know the individual, their risk might be increased. So thinking about providing some additional screening, utilizing outreach, your outreach providers, your care navigators, your community health workers, your peer support during this time is really critical. You remember I said earlier, they can be trained in screening. So this isn't one of those times where you might really want to utilize those that training and that their ability to do that out in the community with people as needed. So the goal is really to promote healing, as we said, but also to reduce further loss and further risk. And then promote safe messages and really monitor those memorial activities and provide community education in time. There's certainly there's some caution here right after a suicide. You don't want to start inundating the community with safe talk or QPR, because people might inadvertently feel like, oh no, we missed these messages. Postvention should happen in some time following, that initial grief response, support, and risk monitoring. Next slide. And again, this is really kind of just what I said about your role, having the opportunity to be a part of supporting the community in that response, with the people that you're working with individually, revisit their safety plans, connect with caregivers for people that you might be concerned about. Be attentive to social media. This is particularly important, I think, and is done very well, very often in schools following a postvention, but adults utilize social media too, and people share a lot of things on social media. So if you have clients that you're concerned about, community members that you're concerned about, be attentive to social media. If you can, you don't have to be friends, but if you can view some of this or be alerted by someone else, it's very helpful. And really consider, activating some of those follow-up care strategies, maybe enhancing that during this time of postvention. So next slide, just taking us back to where we started. There's lots of opportunities throughout the suicide prevention continuum to provide that follow-up care, from those initial screenings, making sure people get connected. So many of you are doing that in the context of your crisis care work and are doing a really wonderful job of that. Just an encouragement to maybe think about other places in the community where you might be able to support and perhaps even educate them on what is all working for you and how it might work for them as well. Intervention, safety planning, lethal means safety. These are brief interventions and can really have an impact on not only maintaining safety, but keeping people connected with care, and then thinking about some of those strategies we talked about, like caring contacts, peer support, and care coordination. And then, of course, postvention. So I think that is it for me. On the next slide is that QR code to the link that has some of these resources that I've been talking about, including, if you follow those links, you'll get to the CALM training. And I'm happy to answer any questions that anyone has.